Hello. Thank you so much for taking some time out of your day to watch our presentation. My name is Barbara Ebersole, and I'm an assistant research professor and the director of speech pathology at Fox Chase Cancer Center.
And my name is Katie Donikoff, and I am a senior speech pathologist and assistant research professor at Fox Chase Cancer Center. And we are excited to talk to you about our project, nasogastric tube feeding for radiation-induced dysphagia in patients with head and neck cancer. We implemented this project at Fox Chase Cancer Center, which is an NCI designated comprehensive cancer center in Philadelphia, Pennsylvania. This project was successful due to our great multidisciplinary head and neck team, and we'd like to credit in particular the following areas: nursing, nutrition, speech pathology, head and neck surgery, radiation oncology, and medical oncology. Head and neck cancers include tumors of the mouth, pharynx, and larynx. Most patients are treated with radiation. Radiation-induced inflammation and mucositis leads to dysphagia and difficulty swallowing across the course of treatment. For some, these symptoms are severe enough to necessitate an alternative method of nutrition. For these patients, surgically placed percutaneous gastrostomy tube or PEG tube placement is the standard of care at our organization. Quality of life is an important consideration in head and neck cancer, and swallowing dysfunction is a known side effect of treatment. Recent research demonstrates that the type of enteral feeding route used during radiation can impact long-term swallowing function. There is preliminary evidence showing that patients who receive a reactive nasogastric tube, or NG tube, for acute dysphagia during head and neck cancer treatment have better long-term swallowing function than those who receive a PEG. The aim of this quality initiative was to implement a process for utilizing NG tube feeding for acute dysphagia during radiation treatment for head and neck cancer. We recognize that some patients would prefer PEG to NG tube, and we compared the outcomes in the two groups in order to better understand the potential benefit of this change in practice. Over the past 2 years, we've collected data for 119 patients who underwent radiation or chemoradiation. The circled group is really the group that we're interested in, those who underwent reactive tubes for dysphagia. Of the reactive tubes, approximately 50% were NG tube and 50% were PEG, making it easy to compare how NG tube, or the new initiative, compared with PEG, standard practice. Our first goal was to improve diet to fully oral by shortening the tube duration. Removal of the tube necessitates meeting all nutritional needs by mouth, a therapeutic and normalizing process for the swallowing musculature. The NG tube group had the tube in place for a mean of 29 days, while the PEG group had the tube in place for a mean of 106 days. Our second goal was to improve timeliness to the highest safe diet level, and we measured this using the FOIS scale, where 1 is the worst, or NPO, and 7 is the best, total oral diet without any restrictions. This chart tracks timeliness to highest safe diet level via FOIS scale. In this chart and the coming chart, black represents pre-radiation, gray represents week 5 or 6 of radiation, and red represents about 1 month post-radiation. FOIS scores were best for the no tube group as expected, and the no tube group would be the ideal of how we would like reactive tube groups to perform across the different time points. You'll see the reactive NG tube and reactive PEG groups were at similar diet levels across treatment time points. Our third goal was to monitor weight loss, pain, and complications. This chart depicts patients' pain rating on a scale of 1 to 10 across all 3 time points. Reactive NG tube use did not appear to increase pain when compared to reactive PEG use. As seen on the slide, both reactive tube groups have the highest pain ratings mid-radiation, as represented by the gray bars, pain likely being the reason for the need for the reactive tube feeding. However, the post-radiation pain rating, represented by the red bar, was 2 times higher for the reactive PEG group than the reactive NG tube group. This chart demonstrates average percentage of weight loss for each tube group. So for this chart, black represents percentage of mid-radiation weight loss, or weight loss from baseline weight to about week 5 or 6 of radiation. Gray represents percentage of weight loss from week 5 or 6 to 1 month post, so about when they would have gotten the tube to 1 month after radiation was completed. and red represents the percentage of total weight loss from pre to post. We see a similar pattern with respect to percentage of weight loss. Use of a reactive NG tube may have a positive effect on mitigating weight loss compared with reactive PEG. As expected, both reactive groups have the highest mid-radiation weight loss, seen on the black bars. However, the reactive NG tube group lost less weight from mid-radiation to post, which is the gray bar, than the reactive PEG group. Similarly, total weight loss is highest in the reactive PEG group, represented by the red bars. In regards to complications, about half of the NG2 patients developed clogging and 1 experienced dislodgement. And we are currently working on both clinician and patient pathways to improve our clogging and dislodgement rates. This project demonstrated that use of an NG tube over PEG is not only feasible, but resulted in shorter tube duration, at least equal diet advancement, and equal or improved pain and weight loss. Thank you.